This conference will now be recorded.
And we'll read the disclaimers and thank yous to our sponsors. AnCan is grateful to the following sponsors for making the recording possible: Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. AnCan respectfully notes that it does not accept sponsored promotion. Any drugs, protocols, or devices recommended in our discussions are based solely on anecdotal peer experience or the clinical evidence. AnCan cannot and does not provide medical advice. We encourage you to discuss anything you hear in our sessions with your own medical team. And we hope what we will do is charge you with questions and areas of discussion to have with your own physicians. If we've done that, we are quite successful. Caller one, do you need some time this evening?
Somebody's on the telephone. Would you like
Yes.
to tell us who you are? Would you like to identify who? Is it Henry?
This is Henry.
Hi, Henry.
Oh, hi, Henry.
How's it going?
I would say good to see you, but all we see is that where it says caller one.
I'm calling one.
Will you need some time tonight?
Yes, just a minute too.
Okay. So Michael V is new here, and what we'd like to do is have you share your story, and we can give you input. I think the best we can do is also ask questions, and that way you know what to go back and find out from your own medical team as well. I will interrupt. Maybe Rick will interrupt. We'll have some other questions for you, just to make sure that we understand what may be going on. So why don't you start off and let us know what's going on?
Thanks. Good evening, everyone. My name's Michael. I'm 60 years old, and I recently found out that I have prostate cancer. I don't know how much detail you want, but I have a lot of detail I can dump on you in like a few minutes if you're interested.
Sure.
Such as in June, I went for my annual physical. My PSA score from last year jumped from 3.9 to 4.6, which triggered a referral to a urologist. The urologist was in July, did a DRI, digital DRE, said he didn't feel anything, but recommended an MRI. So I went for the MRI, and it came back high RADS category 4, 1 lesion, and it gave me a T2 score on the MRI in July. I have more information on that, but I'm not sure what might be important or what might not be important. Such as like at the bottom, it says neurovascular bundles, uninvolved, lymph nodes, no, pelvic lymphadenectomy. Okay. So after that, after we got those results, then the urologist says we need a biopsy, which we did on August 20th. It came back with a score of T1C, 13 cores, 7 were benign, 6 cores were cancerous. 1 was on the right side, was scored 3 plus 4, so 7. Everything else was on the left side. 4 were scored at 4 plus 3, and 1, the actual lesion, I guess, that was discovered by the MRI, scored as a 4 plus 4, as a Gleason 8. So that's the score that they gave me from the biopsy. Following that, if you have questions, just stop me. Otherwise, I'll try.
No, go ahead. Go ahead.
So after that, in September, we did the PSMA PET scan, which identified 2 discrete foci of increased activity, both on the left side of the prostate. No indications of any metastasis, which is good, I guess. So it means, if I use the right terminology, it's localized. At this point, it's localized. In between all of this, I've seen doctors, obviously, and so it's been like a tornado of information and doctor's visits since the biopsy. I met with 2 surgeons and 2 radiation oncologists. Everyone pretty much has recommended surgery to me. My urologist is a specialist in HIFU, and he said he wouldn't do it on me. He said if I want to go HIFU, I got to find another urologist because of the location, the way it's spread across the left side. Something about he would destroy all the nerves on the left side if he did HIFU, in his opinion. So the surgeons, of course, want to do surgery on me. The radiation oncologist said they would probably recommend surgery too. So that's the direction I'm heading. I need a cardiac clearance because years ago I had AFib, which it's gone. I'm not worried about that, but they won't do the surgery without that clearance. But my questions, I just have a few questions. You might have questions for me.
Yeah, let me go over first, and then we'll go from that. The surgeons and radiologists, were they at a National Cancer NCCN Center of Excellence, or were they simply private practice generalists?
So my family doctor referred me to private practice specialist. That's my urologist, and then he referred me to a surgeon as part of his team and a radiation oncologist. But right after that, of course, my wife and I decided to contact Memorial Sloan Kettering. I live in New Jersey, just outside of New York.
Great.
So then I met with a surgeon and a radiation oncologist from MSK, as we call it, Memorial Sloan Kettering. And they took the slides from where they did and they confirmed that Gleason 8 was the highest score on the slides. So they reconfirmed that. And the radiologist there is doing it's a test with a decipher test. He said that if somehow that comes back surprisingly good, then I might want to consider radiation, but he doesn't think it, he says that's a long shot. He's just doing it just to be thorough.
Yeah. Did you see Dr. Nagar at MSK?
No, I did not. I saw a doctor named Gaffney. Chris Gaffney, okay. Christopher Gaffney.
So I would try to get in and get an opinion from Dr. Nagar, Nagar, at MSK. And I think John is dealing with that program, so he may be able to share some information with that. There really is no advantage at this point to surgery, but what you might want to do on the MSK website, there is a nomogram, and you can plug in all your information, and it's going to provide you with what you need to know about your options, the chance that it will recur. In most situations like this, with high risk, I'm not sure why they would rush to surgery, or that they would say that the radiation wouldn't work. Rick just posted the nomogram page in the chat window. If you look up top, you see a person's body and the square cloud quote thing, and inside that you'll have the link to that. But there really, whether you do surgery or radiation, it turns out that the effectiveness is similar. And just about whatever you do, you can expect about a 30% recurrence over time. The radiation kind of depends on the different types of radiation. In the past, with a more advanced disease, they would recommend doing seeds and then surrounding that with external beam. But with the newer radiation, with the MRI guided radiation, they're able to better target. But that's the kind of thing I would talk to Dr. Nagar about. One of the things they will frequently say is that younger people do better with surgery. And that is true, but better than what? A younger person is going to do better with surgery than an older person will do with surgery. But that's not really the question you want to ask. You want to ask the question, what is going to be the best outcome with fewer side effects? And it doesn't appear that there's any advantage to doing the surgery over doing modern radiation. The difference is mainly in the side effects, which happen earlier with surgery than they tend to happen with they happen earlier with surgery than with radiation. So that's something to consider in terms of ED and incontinence and all. So those would be points. I guess if Stuart, if you wanted to share some of your experience, and then at MSK.
Mark, what are you calling modern radiation? Or excuse me, what are you calling modern from the term you used a minute ago?
At this point, I would say that the top of the line is either MRI guided with Meridian or MRI guided with Elekta Unity machines. But the CyberKnife S7 has the ability to fire the beam in from an infinite number of pathways. Just last week, there was a study published that really showed that proton, where there's a lot of hype about Bragg effect and it being safer, really doesn't offer that kind of advantage. There's another study coming out that some leaked information suggests that it's also going, another study confirmed that there really isn't any advantage. While the proton is effective and is going to provide good results, often that's going to be 45 sessions at a lot of places versus the 5 sessions with Meridian. So why don't we hit your questions first, then we'll have Stuart talk about his experience.
I think you've already kind of been helping me because I've been struggling with the decision between surgery and radiation, although I feel like I've been being pushed into the surgery for some reason. I don't exactly know why that is, but my goal is to try and return to a normal life after whatever treatment I get, as normal as possible. And I don't want to have. I read a lot online about decision regret treatment. Decision regret. People pick something and then 5 years later you interview them and they're like, "I wish I hadn't done that." And so I don't want to put myself in that position if I can avoid it. And so I don't know if you have any advice. My strategy has been to try and get as much information as I can before committing. Even though every time I go to someone who's supposedly a professional or someone in the medical field, I've been getting that feedback, "Oh, you should get the surgery."
Well, the other thing that you will hear with surgery is either you get it out, or if you do radiation, you can't come back and do surgery later on if it recurs. And that's true. It is more difficult to do surgery, but you really don't need to. Most of the recurrences occur outside the initial radiation field, or using, again, the more precise targeting that we have now, that they are able to re-radiate. And Dr. Nagar has a number of patients that he's treated a second time. So I don't see it. It's a bit older, but there are books by people at PCRI. Mark Scholes wrote a book, The Invasion of the Prostate Snatchers, that I think tells the story about how many of us feel, but I am biased. The worst part about my experience was the 405 traffic in LA. It was easy. I had no side effects doing it. And I'm 4 years, actually, I'm 2 days past 4 years with undetectable PSA now. So I'm pretty happy with the choice. And I think the literature supports that if you go to, no matter what you do, if you go to a center that's going to be doing a lot of cases in a high volume center of excellence, you're going to get better results. One other thing that I didn't mention, and I'm going to turn to Rick again because I don't know the link offhand, but there's something called the PROMISE study, and it's prostatecancerpromise.org with other stuff that Rick is going to put in the link. But if you go there and provide your history, they will go through and run a free germline genetic screening looking at, I think it's 29 different mutations that might come to play later on should you have a recurrence in terms of what kind of treatment. I'm wondering, Rick, I'll ask you on this one, if with a Gleason 8, whether somatic testing for things like P10, tumor mutation burden, and MSI is indicated at this stage.
Not really, but I think what is indicated for sure is that you should get a PSMA scan.
He did.
Oh, you got a PSMA scan? Okay, I missed that. I'd say a couple of other things. First of all, the MSKCC nomogram is really important because it's going to tell you the likelihood that your surgery will be successful. And you can then determine whether you want to roll the dice on surgery or whether you want to skip the surgery and go straight to radiation and hormone therapy. Now, in my own case, I was a 4+4, I was a T3, and there was only a 30% chance that the surgery would be successful. I was younger than you, and I was planning on doing the surgery, and then I changed my mind because I figured I was going to need the hormone therapy and the radiation in any event. That's not to say that the surgery is redundant. It probably adds somewhere between 3 and 4% in the way of benefits. But you know, is it worth all the extra side effects and comorbidities? It wasn't for me, and so for that reason, I just went with two types of radiation and hormone therapy. It's hard to say which way to go. I mean, there is a preference with younger men to turn to the surgery. I'm not sure what it is. You'd have to. Who was the doctor you mentioned? Was that the urologist or was that your radiation oncologist?
The first, so my urologist recommended the surgery, but said I had to make the decision, and he set me up with consultations with a surgeon and a radiation guy, and both of them.
At MSKCC, just talking about MSKCC. At MSKCC, was that doctor the doctor you mentioned the urologist or the radiation oncologist?
He was a urologist.
And who was the radiation oncologist you saw?
Gutman, Dr. Gutman. I forget his first name.
I've heard of him. The problem with you getting a consult with Nagar is it's very, very hard at MSKCC to switch. So, and I'm assuming, I'm pretty sure Gutman and the other guy were both on Second Avenue, right? That this wasn't in Monmouth Hills or in the other.
It was actually in New Jersey, Basking Ridge.
Oh, it was in New Jersey.
I live in, yeah, it was easier for me to get to Basking Ridge than Manhattan.
Yeah, I mean, again, we're not big fans of Basking Ridge or Monmouth Hills. You're better off if you're getting that second opinion going to the city.
Okay.
The problem is that once you've seen somebody there, our experience has been you can't get a good consult in the city because they don't like to do that. It's possible, but it's very hard. It's really, really difficult. You might be able to get to Nagar. If anything, maybe Dr. Mark can help you get to Nagar on that basis, but it's basically got to take somebody who knows Nagar and says, would you see this guy? Because I'm not sure he's getting the best advice. I don't know what I do. I do know I would run that nomogram and then look at the percentages and then think about making a decision from there.
If you guys if you'd like to, Michael, you and I can just step off the meeting for 5 minutes and I can run the nomogram for you and then we can just join back in.
I'm fine with that. If you can tell me how to step out,
Tell
so I'm
me your
still with
phone
you.
number and I'll call you.
Okay.
So one of my thoughts, Rick, and I just say this, is that some of the side effects from surgery can be lifelong. And someone who is 70 or 69 who goes through surgery and has a incontinence or ED has it for a couple of years. And those who have the surgery in their 50s or early at 60 may have 30 years of dealing with ED and incontinence. And, there are things you can do to battle that, but it can be a battle. Actually, before you step away, John, I know that Boykin wanted to say something, and I wanted to have Stuart share his experience because he's undergoing treatment at MSK now, and he's doing a study called the RTIRE study.
Okay, before you go there, Jerry Grimes, this is the low intermediate today. This is did you read the reminders? We've changed the schedule we had to change the schedule this month. Okay, we'll be here tomorrow with an advanced group. You're very welcome to stay in the low intermediate group too, but I just want you to know this is the low intermediate group, okay?
Thank you, Rick. I was wondering why I didn't recognize anyone. I'm sorry. Thank you so much. I'll catch you all tomorrow.
It'll be I forget where you are, but it'll be at 6 o'clock Eastern tomorrow.
Yep, that works.
And you're welcome to stay and listen into this one as well if you wish.
I probably don't have a lot to contribute. All the best to everyone, and thank you, Rick. I'll see you tomorrow.
Bye.
Thanks, Jerry.
Yep.
Okay, Stuart, you're up.
Did you want to do Boykin first?
I don't know. I asked you before he chimed in.
Okay.
You're unmuted, so we'll get to everybody.
Hi, Michael. I am getting my radiation care from Dr. Nagar, and actually, similar to you, I also saw Dr. Gutman at MSK prior to getting with Dr. Nagar. My situation is slightly different because I'm in clinical trial and Dr. Nagar is in that trial. I know what happened with my conversation. I was sent to Westchester because I'm in Connecticut, and they say that as far as radiation is concerned, they want you at the nearest center, which the one thing that might help in terms of getting you transferred to Dr. Nagar is the one exception in terms of is if the type of treatment that you're trying to have is different, that might be the opportunity to be able to make the switch happen. And because I know when I talked to Dr. Gutman, he had said, if I'll be happy to treat you, it'll be SBRT. If you wanted proton, that's done at a different location. I would refer you to them. So that might be your opportunity since Dr. Nagar is all MRI guided, that might help make that switch.
Thank you.
All I can tell you is, because I'm at the very beginning of interacting with them, is I originally met Dr. Nagar before he moved to MSK, and to arrange the consult, he came in on his day off to meet with me, and his staff are fabulous and really cooperative in terms of doing stuff. So I think the world of him, and they've been really, really nice to me. So I would encourage you to do what you can to try and talk to him.
Stuart, I think your thoughts on stressing that you're interested in the MRI guided approach, which I personally, having studied all these, think it is a better approach. That might open the door to getting seen by Dr. Nagar. But you might briefly explain the study that you're doing, because that might be something that they consider for Michael as well.
Well, if he's 4+4, he wouldn't qualify.
Okay.
The study I'm in is for intermediate, only 3+4 or 4+3. The 4+4 would immediately disqualify.
Okay. So let's go to Boykin, and then we had another hand up.
Yes, Michael, this is Boykin. I just wanted to ask, because it sounded like when I was listening that you were saying everybody was recommending you go the surgery route, but did they explain anywhere in your discussions why that route, or on the corollary, why you wasn't a good candidate maybe or the best option to do radiation or something else to you?
They kept stressing because of my age. They kept saying that if you got the radiation first, then you really couldn't go back to the surgery very easily. It's like they kept selling it as there's a staging to your treatment normally, especially if you're my age, is what they would say. You get the surgery first, and if it recurs, then you hit it with the radiation and you're good. And then they would also say the side effects are the same. This is what they're telling me. The side effects are pretty much the same either way. So why not do the surgery, get the cancer out of your body, and the chance that it does recur, then you have the radiation to hit it. And that's how they've been. I don't want to use the word. That's how they've been communicating with me. I don't want to use the negative word.
No, I'm tracking with you. It just seems like, in other words, if I'm reading it right, part of the uncomfort is that you're only getting one side of the story, and so in the end, you're not able to really evaluate what's the best. Yeah, so keep pushing, because otherwise you'll have a decision regret.
That's what I'm afraid of, and that's what I'm trying to avoid. So to follow on that, Boykin, I don't know if anyone has advice, but the other thing they're doing is they're telling me, like, you can't wait long to make your decision because you got to act quickly. But I've read online that prostate cancer is slower growing than other cancers. You don't want to wait too long, but you don't want to rush. So I'm trying to. What's that sweet spot? Do I have like 3 or 4 months to decide, or should I be deciding and acting within a month or two?
So I can answer that one for you. I was 4+4. I got diagnosed with the 4+4 in August, and I was told I had until the end of the year to make a decision. So I would say that, as long as they don't see any metastasis or anything else, you have 60 to 90 days If you want to take more, you can get a hormone shot, which will basically stabilize the disease. If you're not going to, if you're going to do surgery, you don't really need to do a hormone shot up front. But what's the size of your prostate? Did they tell you?
53 cc's.
Okay, that's relatively average. 40 to 50 is sort of the average. It's slightly on the large side. Jim Schrate, you are the master of decision regret, and you've had your hand up twice, and you also moderate this group, so you shouldn't have to put your hand up. You can jump in anytime.
I don't want to be rude. People have more valuable contributions than mine to make here.
Not true.
I'm listening to all this discussion, and you're in the New York area. Does it make sense to get a second opinion at a separate institution and just get a fresh view of this question? Because, turning to treatment regret, I had surgery when I was 58, and I regard it as the worst decision I ever made in my life. I experienced extreme treatment regret, depression, and that sort of thing. And make no mistake, the side effects with surgery are immediate and severe. I have not had a spontaneous erection in 14 years, and I miss it every single day. Whether the ultimate side effects with radiation are the same, it's very clear that they take a lot longer to manifest. And I'm not convinced that they're as bad as they used to be, because that's what they told me 14 years ago. And radiation has improved a lot in 14 years. And, whatever else they tell you about surgery and robots and this and that and the other thing, the outcomes have not improved that much. You get out of the hospital a little quicker, but I had an open procedure. I was out of the hospital in 35 hours flat from the time I walked in. So it's a little kinder, gentler surgical procedure, but the ultimate outcomes are not that much different. And if you look at the studies that use validated questionnaires, permanent sexual dysfunction with surgery is in the range of 50%. Mm-hmm. So, I think, you need to talk to whomever you need to talk to make this decision, because it's a decision.
Yeah. The other thing I forgot to mention is that the other reason they push me towards surgery, or they say the hormone therapy is really bad, like it's really hard on your body, it's going to beat you up, and you don't want to go through that if you don't have to. That's the other story I keep hearing. You don't want to have any.
Is MSKCC telling you this, or are your local guys telling you this?
The doctor in Basking Ridge, the radiation oncologist, said that he thought, using his technique, which I didn't know much about at the time, he would recommend 18 months of hormone therapy, which he thought would be difficult.
Well, there's no question it's difficult, but when you start talking, you come in with some of these emotive words like it's going to beat you up and this, that, and the other. I'm wondering where you're getting that from. I mean, there's a bunch of us who have done a lot of hormone therapy in this room right now. And hormone therapy isn't pleasant, but you're getting information that bothers me. For example, somebody's telling you that you can't do surgery after radiation. That's not true anymore, and I would be surprised if that's coming from MSKCC. That's the sort of line that you hear from the local people, because they don't want to lose you, right? And they don't want to acknowledge that you can do surgery after in these days. So you have to be really, you have to be discerning as to where you're picking up your information, Michael. But There's a couple of messages for you in the chat as well. So here's what I would say. Just I know we have to move on, but I really like Jim Schrait's idea to get second opinions from some really top people. And that will not be now. You might well be able to get to Dr. Nagar using the Stewart strategy or the Dr. Mark strategy, which that you definitely want to talk about MRI guided, and that would get you to Nagar. And I don't know Nagar well enough to tell you how well he's going to compare surgery and radiation, but he certainly knows his radiation. I will tell you that if you want to get a good comparison of surgery and radiation and the pros and the cons, I've got two names for you, both at NYU Langone. If you can get there. How's your insurance, by the way? Is it a problem for you to go to different institutions or not?
Usually not. It's a PPO, Blue Cross.
Okay.
So typically I have coverage, typically.
Okay. So the urologist that I send you to talk to at NYU Langone, who knows us really well, you can tell her we sent you as Stacy Loeb, Loeb. She's outstanding. She's compassionate. She's ideal for this type of radiation versus surgery. She's not going to push surgery if it's not right for you. If she thinks surgery's right, I would rely on her. The other person is Dr. Michael Zalewski, Zelefsky, who had the job that Dr. Nagar now has. He was the chief of radiation oncology at MSKCC, and he recently, like in the last 6 months, moved down to Langone. So he is now at Langone. So that's the name of a radiation oncologist for you and the name of a urologist for you. And Jim knows both of them. I think he knows Dr. Loeb better than he knows Dr. Zalewski, but he does know both of them. Hopefully he'll approve. Do you approve of those choices, counselor? Okay.
Michael, I wanted to add two more things briefly here. One of the things that you didn't mention, and they may not have suggested, was that in about a third of the cases after surgery in a situation like yours, it may be that there is disease noted outside the gland that normally would get treated by radiation, and they come back after the surgery, and then you have the double whammy of first the surgery and then doing radiation and the ADT. Luckily, with disease confined to the gland, it would be a single ADT medication. With a history of any kind of cardiac disease, they might have you see a cardio-oncologist to look at how do we lower your risks with different medicines along the line. No one likes it. No one likes ADT. The longer you're on this, the more you lose muscle strength and calcium from the bones. So it's important to check your bone calcium status before beginning treatment, and then to use a combination of both cardio type activity, but equally and more important to do strength training so that you keep the bones and keep the muscle strength. The other thing that...
Can I just say, that's why we want you to run the nomogram, because that's exactly why we want you to run the nomogram, because that will give you, it is a nomogram, so it isn't true for you, but it's true for people that have disease like you based on a large database. It will give you a pretty good feel for how likely with your disease demographics they're going to find something that requires follow-up. It's exactly Dr. Mark's point, but that's how we quantify that. Sorry, go ahead, Mark.
Okay. And then the other thing that frequently guys will come back and report is that you don't want the radiation because you're young enough that you're going to be hanging around here when you get another cancer. And the real truth is the greatest risk of getting another cancer is having one cancer and not necessarily the radiation, because the risk of another pelvic cancer is about 1.5%, even in those who have surgery. The SBRT may increase it by about 0.5%. With the MRI, which has smaller margins and about a 60% reduction in normal tissue exposure. It may be even less than that, but those in themselves are not necessarily a signal that you will die from this secondary cancer. But that's one of the arguments that they also get. But I agree with Rick that the language that you're sharing with us is really someone who's trying to push you and mislead you into making a decision that may not be based on the information. PCRI.org is a great place to watch videos on this. And there's another doc who has experience with the MRI, Dr. Kishan, and you can go on YouTube. Kishan is out here in sunny California at UCLA, Kishan. Both of them will have videos on radiation therapy for prostate cancer and great talks, and it might help explain why, at least why I push that as being state-of-the-art approach at present. Let me see here. John, you have your hand up.
Yeah, Michael, you have AFib, correct?
I had AFib. They did cardiac ablation on me 10 years ago. It was actually a flutter, which is a type of AFib,
Right.
and has never returned.
Okay.
I have been in normal cardiac sinus rhythm for 10 years.
Are you on blood?
I couldn't hear that last question.
Are you on blood thinners?
No, not at all.
Because I had two ablations with one of the best, Natalia, and it just got wild. So I just thought if you were blood thinner surgery, it would be hard.
Right. No, I'm lucky in that regard.
Okay. I guess if you wanted to drop off with John and then come back, we'd love to have you come back and join us again at that
just
point.
One last question. Do we have your email address? Have you up? I see. We will sign you up and make sure you get a reminder. Just a quick pitch. Actually, I won't do a quick pitch because if you're going to speak to Dr. John will tell you about Men Speaking Freely if you need it, because he's our Men Speaking Freely expert. And the other thing is that, and you can choose, we usually talk to men with Gleason 8s and higher in the other group, because that's where we really get into hormone therapy. We don't talk about long-term hormone therapy in this group because it can be a bit scary for some of the guys. So if you want to know more about hormone therapy, you can come to the high-risk group. So I'll sign you up for both. You choose where you want to go. And I'll sign you up for the Men Speaking Freely. If you want to change your mind, go in and change it. Don't unsubscribe because it'll take you off everything. Okay? All right. And you guys can you can just mute and shut your cameras, and you don't have to move out of this room if you're going to be talking on the phone.
Thank you very much.
Pleasure.
Okay. Paul, you're up next.
Okay, just a reminder of where I am. I'm decided to get treatment, radiation, 28-day course because the radiation causes said my tumor is too close to the urethra, so he doesn't want to get. He's a little more cautious about the 5-day higher dose. So So had my medical clearance today, so I'm scheduled for the fiduciary markers and the spacer coming up in 2 weeks. A couple of questions as far they gave me a list of how to prep for that. The one thing I noticed is different. I had multiple biopsies in the past, and I never really had to do all these medical clearance, meaning they did an EKG, they got blood work. So is you gonna be under anesthesia longer during this fiduciary and spacer procedure versus the biopsy? Is that why they, was that just because of the radiation oncologist preference or a more thorough check of your current health status for those who had the procedure?
As far as I'm aware, I would expect that it would be fairly similar to the biopsy, maybe less. Normally, the fiducials and the gel is placed by the urologist and not by the radiation oncologist. So I would think that if it's the same person, it may be that you're just older now that they've decided to do this. I'm not really sure why there would be a difference in terms of the procedure with cardiovascular risk doing the fiducials in gel.
So yeah. So actually, my the radiation oncologist will be the one doing the fiducial and the spacer. Same guy. Okay, and
Now,
then
are they planning on doing sedation? Because they can do it with
yeah,
sedation as well. And if they're planning to put you to sleep, then they might want that.
yeah, they are. They are. I'm going to be on anesthesia, and I think the whole thing lasts. They expect me to be there for 4 hours, which is I think that's a bit longer than biopsy total time too.
Well, most of that is the getting ready and the waiting and getting into a room and getting set up and getting all the monitoring going. So the actual time that we work when we're doing the procedures is a small percentage of the time that they talk to you about. Then you got to recover after the procedure and wait till you're up and alert again before they can let you out. So that would not be unusual for it to be a couple of hours.
Okay. All right. And then after that, it'll be 2 to 3 weeks when I start the treatment. So I think that's the typical, right? Is that just to wait for things to settle down? Oh, I'm sorry. I'm sorry. So after the week after that procedure, I'll do this MRI and CT scan and planning session. Okay. And then after uh, that routine, then it'll be a 2 or 3 weeks before the therapy start. So I think that maybe just part of scheduling and part of they want to set. Oh, they have to do more after they plan. They got to get together and do all the final planning, check the boxes. Is that pretty much typical?
Right, and they have to they load the thing on the machine. They plan in a couple of different dimensions, so it takes a while to look at the plan, make sure that the doses to normal tissue, and in your case, the urethra, that they're working to protect that. So that generally is going to take 3 weeks would be long, but in most cases, it's going to be 2 weeks. That the plan from the CT, MRI to the ultrasound, or to the actual starting of the treatment can be usually about 10 days to 2 weeks.
Okay. Did any of you guys for this do any as far as just getting all the side effects as possible? I thought about starting some kind of like Kegel or pelvic exercise ahead of time. Is that something that's probably should consider just to get the issue of incontinence get ahead of it if it happens?
Well, with radiation, the incontinence is so rare. Urologic side effects in the first month or 2 months are not unusual. There can be some urgency and frequency and perhaps some mild dribbling or incontinence. But after that, most often it goes away. Kegel's exercise never hurts anybody, but as a standard for radiation, I don't know that that's something that would be recommended. Now, oftentimes they will recommend Cialis to preserve blood flow to the penis during the period of radiation, and then perhaps tamsulosin as well. So those are questions that you might want to ask, whether they're going to put you on any other medicines during the radiation therapy.
Okay. All right. Thank you very much.
Great. Let's move on. Stuart, did you have?
Hold on a minute. Can we ask anybody else who has either gone through radiation or prepped for radiation if they have any words of advice for Paul? Anyone else in the room that might have anything they want to say about preparing for radiation? It's not.
Yeah, I do.
Okay, thank you, Boykin.
Okay, so one of the things that I think that is important about radiation is getting into a good daily regimen, because a lot of it depends on your, at least in my case, on your bladder size being full and your rectum being so much emptier and things like that. And the time of the day for those kinds of things matter. So generally, the earlier in the day for men, the better is what I experienced. I had two different times, and when I started out like at mid to late morning, my sessions were a little harder, and then they moved me to like starting at 8:30 in the morning, and that worked out a whole lot better. But to me, the big challenge is just getting a cycle, getting a daily rhythm so that your body can do as much naturally as possible. And then I would just say, if you still need a little help, don't be afraid to drink a little prune juice, which did the trick for me, and figuring out the right rhythm so that you can have all your movements at the right time. So that would be my advice: is figure out a rhythm as soon as you can, and then after that, it's all downhill from there.
Okay, great. Thanks for that. Yeah, the concern is about the whole the urination until it actually starts. So I think that's a great challenge. I think I'm going to start practicing.
Well, it is, and because you have to do it every day, you will get that part. So the number one side, the urination, is easier to manage than the bowel side, which is why I focused on that, because at some point they're going to just dump so much water in you that it's going to happen, and they'll get what they it to be. So in other words, I'm saying is a empty bladder is less of a problem than a full rectum.
Okay.
Right.
I'd
also, problems, but yeah.
I'd add to stay away from carbonated beverages, and probably not having coffee or something that's going to make you urgently pee first thing in the morning.
Oh yeah, definitely.
It's one nice thing with the newer SBRT and Meridian, and then also with the CyberKnife, is that they now have adaptive planning. So it looks at where things are that particular day, and on the fly can readjust the plan that, oh, today you have a little bit too much gas in the bowel, or there's some stool there. It'll recreate the plan without having to go through. And I know when I went through, it was only 5 days, but each day there was a little bit of trial and error in terms of how to deal with driving from the Valley to UCLA and having the proper amount in the bladder at the time.
Yeah, I think by the fifth day, I think we figured out the first 5 days is going to be the challenge. And unfortunately, I'm not. Yeah.
Or maybe 2 or 3 days, and after you get that, it really is actually a pretty easy thing. The one nice thing about what you're doing, compared to the MRI. The MRI can be up to 40 minutes each of the 5 sessions, where most of the other linear accelerators that use a CT guidance will be a lot quicker on each session.
Yeah, I think it's around 15. So I think my plan is I will have one of this pee bottle right next to me on the table. So as soon as I turn the machine off, I'm releasing opening the gasket. I'm not there. I'll make it to the bathroom. So
Oh, I
okay,
think
thank
they'll have a
you.
plan for you. I think you'll be okay.
Yeah.
The big old plastic sheet on the table. Okay, all right. Thank you.
Okay, Stuart. Yeah, Stuart, you were up next, I think.
Hi, just a quick update. I am 3 weeks and a couple of days post focal treatment, and there's still some little bit of urinary issues that are starting. They're still in the process of clearing up, but so far so good. And in 2 weeks, I do start the preparation for the radiation. I have the simulation planning session, and then 10 days after that, I start the first of the 2 actual radiation treatments. So by mid-November, I will have had both treatments.
What kind of urine issues are you experiencing now? And this was IRE that you chose, right?
Yes, IRE. I had a catheter for 5 days. After the catheter came out. The first few days were real, and they had me on Flomax from the time of the procedure. And initially, the ability, trying to pee was difficult, but there wasn't any retention. It was just a slow process. That has gotten much better quickly. I still have some pinkish tinge to the urine. They say 3 weeks. That's not unusual. I still have some urgency. I'm up probably at least once not in the night to have to pee because it's too much. But in general, it's getting better, and it's not anything that's not dealt with. And from what they tell me, it's not outside the norm of what they've experienced. That they say 4 or 5 weeks of after effects is not unusual for the procedure.
So with IRE, is the catheter a standard, or was it because of where your lesions were located that they went after?
The standard. I think Dr. McClure is a little bit on the conservative side. But they had told me in advance it would definitely be 5 to 7 days as a given, and that they would know better after the procedure. And so I had my procedure on a Friday and my follow-up and removal on a Wednesday. But I know I know in some other cases it's been a few days longer. So they're really strict in terms of making sure that there isn't a serious risk of retention before they let you out of the hospital after they remove it. Especially since I'm an hour and a half or more away from the hospital, so they didn't want me having to run to the emergency room locally.
Any other comments for Stuart on that procedure as he goes through?
Stuart, when you were saying pinkish, is that blood?
Yep. It's it's not serious blood. They say it's described as me. It looks sort of like rosé. If you could see it through it, it wasn't a concern.
Radio, thank you.
Yeah, I just want to say it's not unusual, Nick. When the urethra gets irritated, as it does with these procedures, it's quite common that you'll get a little small amount of blood in the urine. I mean, when you're peeing blood, that's a whole different situation. But it really is not unusual. The other thing I think for Stuart is
sort of
that
similar to a biopsy.
yeah,
Probably less than a biopsy.
You know, it all depends, and it just depends how it's been aggravated. I mean, I used to get blood in my urine when I exercised too hard, like on the track indoors during the winter, and I would come home and I'd have it. So it's not something that we concern ourselves too much, and I think you should be prepped. The doc should prep you to expect it and not to get too nervous about it. Now, if you see intense blood, that's a whole different situation. Corsley, did you want to say something about that?
No, I just wanted to ask Stuart a question. Given the kind of aggravation and the discoloration of the urine, is there any chance of developing a UTI during that process?
We discussed it, but I had no other symptoms, and based on what I was seeing and what they interpreted, they said 3 weeks out. That's totally within normal. To watch for any signs, any other signs that would suggest UTI, and if it continues a lot longer, they would follow up, but she didn't see any reason to have to do a test now.
Anyone else? If not, Henry, you're up. Henry?
Are you there, Henry?
I guess maybe taking a break. So I have
okay, somebody just put a message in. Someone is waiting unlocked to let people in. We do not have a locked room. So anybody can come. I don't know who that message came from, but it doesn't make sense for the room that we have. So I don't know. That might have just session unlocked. I don't know what session locked, session unlocked. Shouldn't be locked. Anyway. Sorry, go ahead.
John, you're
yeah, I just wanted to say I had issue. I was locked out, so I kept going in and out. You got to update the app. I tried that, so that it's locking people out. Still.
We don't have John. We don't have a locked room. That's the thing. I don't know why. This is a standing room that's open to anybody, and there's no password or anything. But I will check with Miss Alexa tomorrow.
Rick, when I looked up, when that popped up, the lock was locked. So I unlocked it. So I don't know how it got locked, but the lock was on the room. Well, it was
me out.
Yeah. Anyway, okay. So I want to go through the list here because we have some people who signed in after we got started here. So John, do you need some time today? John A. Nope. Okay. And Nick, do you have any more that you would like to bring up and share with the group?
I have a short comment when you're ready for me.
Okay. And Dale Barber, do you have something to discuss?
Nothing today, thanks.
Okay. And let's see, Jerry Grimes was the other group. Brian, I don't see Brian any longer. And Tom Wilson, would you like some time today? Tom? Okay,
Sorry,
we'll get back.
can you hear me?
No. Okay.
Yeah, I'm new to this. I was just recently diagnosed with prostate cancer. I'm more listening only, or more listening than sharing my thoughts. But so this is my
Well,
first.
if you'd like to, we generally go through the new people to the group first. And if you would like to share your story, that would be great. If you want to just hang out and listen, that's all right too. Make sure if this is your first time here that you put your email address in the chat, and that way you'll get notifications of the next session.
Okay, will do.
Tom, you can put that into one of the moderators, to myself, to Rick, or one of the others if you don't want to put it in publicly as well.
Okay, all right. I'll just figure that out. I'm technologically challenged in some respects, but yeah, no, I was just diagnosed a couple weeks ago, and I'm trying to figure out what the best course of action, whether it's surgery, radiation, and others. So I'm just trying to gather information. I'm 57 years old, live in the Chicagoland area, and I guess that's about it.
Well,
if I may, Tom, I'm very new also, but I would just recommend that if you don't mind, the moderators are good listeners.
Yeah. Yeah.
So if you would like to share a bit more, how did your diagnosis get made?
So my PSA score went from like 3.5 to 7. Then I had a biopsy, and I had a Gleason score of 4 + 3, 7. I had 7 out of 12 cores test positive, and so I'm learning more about it. So it's relatively new.
Did they do a MRI before the biopsy?
Yes.
Okay. And have you had a PSMA PET scan yet?
No, I'm having one next week.
Okay, great.
Yeah.
That hopefully, I mean, they're not 100% sensitive, but they do pick up lesions that are outside that obviously can change how the treatment is. The addition of the PSMA PETs to our evaluation oftentimes will change what is recommended in about 30% of the people going through. Another thing that you may find in the chat window, which is a little cloud square next to the body in the upper right part of the screen, a list for the prostate cancer promise study, prostate cancer promise.org. And they do free.
I've got to put it in. I'll put it in right now. Sorry, I slipped up.
So that's a free test. You put in your history, but they run genetic screening, germline genetic screening for 29 different mutations. We have 2 types of genetic mutations. One is called germline, which is basically what you got from a parent. It's in every cell of your body. And then the other is somatic, which is just what's going on in the tumor itself.
Right. Okay.
What are your thoughts, and have you gotten any opinions from people yet on surgery?
Well, most of I've had 3 opinions, and they all say surgery. I'm 57 years old, and they think that that's the best option for me. I'm having more opinions later this week, like into next week.
So we'll get some names again from people in the Chicago area that Rick can help us with. But were you on board when we were going through this and explaining to Michael some of the thoughts about surgery versus radiation and age?
I was not. I joined them half hour late. I'm sorry.
Okay. So let me give you some of that. I apologize to people who may have heard before. But quite often, urologists will push younger people towards surgery because younger people have an easier time with surgery. Now, the question is easier than what? and it's not easier than radiation. It's easier than a 70-year-old going through surgery who has greater risks. Jim Schrate can share with you his experience where you make a decision on surgery and you may end up living with that for the next 30, 40 years. So that's not generally the case with radiation. The side effects with radiation, if they occur, tend to be late. Another thing that people hear is that you do surgery first because you can't do surgery after radiation, and you can do this first, get it rid of it, and then go ahead and do radiation later on. The thing is, if you do radiation once, you can do radiation again. That doesn't matter, and there's no point where really managing with surgery is better unless there's a lot of difficulty with prostatic hypertrophy where you're having to cath yourself to pee, then the surgery is advantageous. If not, the modern radiation oftentimes is a lot easier. Now with SBRT, most people can get by with SBRT with 5 sessions, don't need a catheter. Right. And it's less than maybe 3% are having some early side effects that tend to go away after a month or two. So it's something that you have to be careful. It's important to make sure that you're getting opinions not from your community urologist, but from someone at a center of excellence where they have different modalities of treatment that they can make available. Okay. And Jim, why don't you go ahead?
Okay, I had a couple of thoughts here. The first question I had for you is, have you gotten a second reading of your slides? I didn't hear how many cores were Gleason 4+3, but out of the 7 positive cores, or was it more than that? What was the breakdown?
I'd have to look. You're asking me, I presume. I think there's 3 or 4 that were 4+3 out of the 7.
Okay. Normally on an initial diagnosis like this, we would recommend that you get a second reading of those slides because the scoring of the tumors as evidenced by those slides and the interpretation of that really underpins every single decision you're going to make from here on out. So we recommend that they be reread. Johns Hopkins has an excellent program for that. And Ming Zhao is where, Rick or Mark, now?
Mount Sinai in New York City.
He's at Mount Sinai. And
Mount Sinai.
I'm just going to put his, I'm just putting his link in the chat window for you.
It's just, you really need to have a comfort level with that information. And get them led by experts. Who are you seeing in Chicago at this point?
So I'm seeing a couple, Dr. Ashley Ross, and I'm seeing Brian Helfand.
Okay, I mean, they would be my 2 top picks, among my 2 top picks in Chicago.
Okay. Yeah, I'm seeing Helfand on Thursday.
Yeah, they don't come much better than Brian. So you're in hands, and he is not gonna push you into any treatment that you don't really need.
Okay, great. Thank you.
You can trust
him. Yeah, you can tell Dr. Helfand that you were in an AnCan group with Jim on Monday night because he knows us very well.
Okay, great. Thank you.
And Dr. Ross is equally, I think, a good choice.
Okay, great. Thank you.
And who actually did the biopsy? Was it
Ross?
I'm sure you can ask him to send the slides to Dr. Zhu. He'll know what to do.
Okay, great.
Or to Johns Hopkins. But we do recommend that you get a second opinion on that. So, sorry, Jim, for jumping in.
Okay, well,
No,
thank
no,
you.
that's right.
Thank you. I'm glad I joined.
I was pretty much finished, and I would say, come back and see us after you talk to Dr. Halfan. We, be very interested to hear how you're doing and how your decision process is going.
Yeah, thank you. Yeah, great.
Yeah. Tom, make sure you send us that email address because we send out a reminder before every meeting.
Okay,
How did you find us? How did you find us, by the way?
David Muslin.
Oh.
Oh, okay.
And yeah, that's oh yeah, yes.
So
I knew I
he's
knew
I think
your
on your
name.
board.
Yes, I knew your name from somewhere. David sent it to me last week.
Yes.
So yeah, we'll make sure that you're yeah. Yes, we love Mr. Muslin, and now I know who you are. So yeah, we're good. We're all
Yeah,
good.
well, good. Well, thank you. It's great to be here. I'm sorry I joined late.
Anybody else have any comments for Tom?
Okay, I don't have a comment to Tom, but I sent Michael a private message with my phone number. And so, Michael, I had surgery a couple of years ago. And so if you'd like to visit sometime and discuss my surgical experience, I'd be glad to talk to you.
Okay, great. Thank you.
And Nick, I think you're up now.
Could I interrupt
Okay.
for just a second? Rick, oh,
Sure.
never mind. You corrected it. I was looking at the chat. Ming Zhao's email address initially went to just the organizers. I see you corrected it.
Okay.
Tom, can I just before you go, Tom, do you want me to use your business email, or do you want to send me a personal email for this?
Either one is fine. It's pretty private. Do you have my business email or?
Yes, yeah, I do. I have your business. I'll
That's
sign
fine.
you up on you. Okay, thanks.
Okay, thank you.
Okay. Well, my short report is that I've been doing a lot of investigating. In fact, I had a consultation at Ashley Moffitt this past Wednesday. But the real reason I was wanting to talk is because I guess I should say, accepted to be considered by the ITRIE trial in New York City, and I'm going there. I have appointments on Wednesday, October 30th, getting a PSMA PET scan on the 31st, and I'm set up for a biopsy on Friday the 1st. So we'll find out where I stand. The way I feel about it right now is that hopefully I'll pass, but certainly I'll be gaining information. If I get rejected, I'll know why. And that's my short report.
What did you hear from Moffitt?
Moffitt, I met with Dr. Alice Yu, and unfortunately they didn't have my slides yet, which on the good side of that, they have GU pathology specialists. So I'm looking forward to seeing what they say. To answer your question, Mark, Dr. Yu recommended IRE or TULSA Pro. She also warned me that there's relatively high recurrence with the focal therapies, mostly out of field, but nevertheless high percentage of recurrence. It's one of the reasons I'm sort of psyched up about the ITIRE trial, but nevertheless, she did conclude that she would be able to treat me, and that IRE and TULSA Pro were the two methods that she recommended that I look at. She also recommended that since I live in the Portland area, and she knew OHSU, who I'm having a meeting with next week, did the electroporation, that if I chose to do that, that she recommended I should do it at home. Of course, she didn't realize that my brother lives 10 minutes from the Moffitt Hospital, but nevertheless, so sort of positive all the way around, at least for now, in terms of me being able to understand what my situation is. And who knows, maybe if things work out, I'll be doing the same thing that Stuart is doing.
Sounds great.
Is Stuart, Nick and Stuart, are you guys in contact with each other?
Oh yeah, I forgot to say this. Mark and Stuart, thank you so much for talking to me. They both talked to me at great length.
Okay.
And so I'm very appreciative about that. And Stuart and I may even have some lunch. Although there's a few times that I'm going to be in the area. You know that anyway, Stuart. If I pass, there'll be a few times that I'll be in the area. So there'll be other opportunities for us to connect. I happen to be, I don't see Michael. Oh, if Michael, I'm from Ridgewood, Michael. And if you know where that is. And so I'm from Bergen County. And I'm going to be staying in Bergen County when I go up in the end of October. And also when I, assuming the positive for right now, also when I get the treatments. Everybody else doesn't know what Bergen County means. That's the county, the George Washington Bridge goes into Bergen County.
I know exactly what it means. I used to look out my window and watch and look at Bergen County for a whole number of years.
Yeah, so I'm from a little bit north of New York City. And I'm psyched up about it, but that's the end of my quickie report. Just wanted to let you guys know what was up.
Sounds great. It looks like from the list here, no one is in line for hurricane number 2. Are we all sitting safe from that?
Well, my brother is. He's in Tampa.
Yeah.
So hopefully he doesn't get it, but
yeah, and I think I shared with the organizers in the chat window that one of our other moderators for this group, who's been pretty occupied the last few weeks, Bill Franklin, is yet again in line. He moved out about 40 minutes away for Helene, and then there was 2 to 3 feet of water in his house and his mother-in-law's house, which is on the same street just down the road. And I called him today just to tell him I was thinking about him, and they were drying stuff out on his front lawn, and he was getting ready. He's already evacuated from the houses. He was just there because they were doing work. They've moved up to Clearwater until they can get back into the house. But he's not happy with the structure in Clearwater, so they're going to Orlando, where his family lives. So he's really been through it. And then we have at least a couple of other guys that I know of who are in line for the storm. 3 other guys. So we'll see how they do. One of them is 2 of them it's their winter home, so they're up north right now. So I just feel for these guys. I mean, it's just miserable to have to clean up, come back, and then you're right in the eye of the storm again.
We had looked at retiring in Asheville, so we just thank ourselves, because the one street that they show where all the artist colonies were, that was our place. We always spent one day during our Asheville trips going through all the artist studios, and they're all gone now.
Yeah, wow.
So they got.
I think we lost. We must have lost George from Toronto. I don't see him anymore.
Yes, he signed off.
Yeah, I think he had something, but anyway.
So if anybody else has anything they want to bring up, please feel free. Henry, if you're there now, join in. If not, we'll sign off for the evening. And our next session is in 2 weeks.
Yeah. Henry, where are you?
Yes, I'm still here.
Okay.
I just had a quick question. My question was, I got a PSA test coming up. I had COVID, and I was told that the COVID will cause a spike in my PSA. I just want to know anybody experienced anything like that from taking a PSA and having some type of illness in the process, or I've since recovered. I just wonder, has anybody experienced anything like that before?
We've seen it, but it's usually with people who still have COVID, but if it's been gone a couple of weeks or more, we haven't seen it. But yes, and it's been recorded that you can get a spike from COVID, but it's right around the time. Dr. Mark?
Well, yeah, that's, it's been reported and we've seen it. I would say don't get alarmed if it's up. If it is up, I would say just chalk it up to that possibility and repeat it in a month's time, and you'll see it should come back towards normal then. But I agree, Rick, in 2 to 3 weeks, it'll probably be, once you're over and done in 2 to 3 weeks, it'll probably not be an issue for you. And I got to celebrate with the COVID friend last week, and it was not fun.
Yeah. Yeah, and Len Sierra going through the throes of it right now. He started what's it called? The drug with a P.
Paxlovid.
Paxlovid. He started Paxlovid. Yeah, and it's been effective. It's brought his symptoms down, but he's not a happy camper. Dr. John, did you and Michael figure out the nomogram?
Yeah, we ran the nomogram, and I sent him everything. So he will bring it to his consultant and help participate in deciding whether to have a prostatectomy or not. I would just say I'm sure everybody's curious, but it didn't really come back saying that. I don't think that it came back saying that surgery was a great idea.
One of the things that I'm concerned about the nomograms out there is they are developed and applied when we didn't have any of the information from PSMA PET scans. So, and that's one of the problems with evidence-based medicine, is that we say something doesn't have an effect or is not effective, when what we really mean to say is we really don't have the studies that show what's going on. When you have a study and you're trying to make a decision based on the information, you have to understand the population of people that were in the study that allowed you to gather that information. Now that we have PET, all that's confused. And in fact, that's an issue with all the treatment protocols, because most of the published studies that are used as guidance, generally for more advanced cases, are done without the benefit of knowing the PSMA status on the patient. So I think there's a whole lot of work that has to be done. The PSMA is great. It's good to have that information. But there's still a lot of arguing among physicians about, do we take that into account, or do we treat people blind to the knowledge of what the PSMA PET shows? And that's my concerns about nomograms.
So what was the percentage?
50 or 56 or something, wasn't it?
Right. Right in the middle. Okay. Okay.
56
Yeah. Yeah. Yeah, it's tough.
for
It's
for freedom from recurrence.
yeah.
I'll be out in a minute.
Yeah. 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 Yeah.
Hey Rick, quick question. That spike in the PSA that's brought on by COVID, does that mean someone like myself who's currently testing undetectable could have a spike if I get COVID?
Um, Probably not, because you don't have a prostate and the numbers are too low. I mean, where we've seen it is with people that have a significant amount of prostate of PSA in their body, either because they haven't been treated or they're metastatic and they have a level.
Okay.
John S., you have your hand up.
Yeah, I don't know why I'm getting feedback here. I was watching Dr. Gio's podcast, and Dr. Elif Eldafi from Sloan Kettering, he's doing focal one HIFU treatments. So, any opinions about that?
Well, I'll just say we have through patients, we have a bit of a history with Dr. Aday, and he's not somebody that I'm a big fan of.
Okay.
And yeah, he's been pushing this HIFU for a while. He's kind of the focal treatment guy. But you know, we've seen him try and treat people that subsequently had whole gland treatment, either surgery or radiation. I mean, we talked one guy who was a big fan of ours. We liked him very much. He was a regular, and we got him in the end to drop a day and go to Eastham, and he got very good treatment from Dr. Eastham.
Okay, yeah. He's, I know he's miserable, his prior treatments. I seen on a web, so now he's back at it with one. So, I don't know.
My concern is that I've yet to see a study that says that focal treatment is any better than active surveillance. The problem is focal studies mostly are defined as disease confined to the gland, and if you have a low volume 3+3, you really ought to be doing active surveillance. If you have 4+3, in most cases, you ought to be doing treatment. So the studies on focal ought to be limited to 3+4. The data that we have so far shows that focal is very effective. Not effective at curing the disease, not effective at reducing radiologic progression, not effective at reducing death rate from prostate cancer. What it is effective at is delaying the time until definitive treatment. So it's great at kicking the can down the road. If you want to go through anesthesia, spend money, use a catheter, then that's fine.
Yearly biopsy.
This is a multifocal disease, and we know that there are a lot of lesions in the gland that may not show up on the MRI. And those are probably not the ones that are going to get us in big trouble. But the MRI doesn't accurately reproduce the size of the lesion. So if you're just treating what you see on the MRI, you may be undertreating some areas and overtreating the others if you're doing whole gland. To me, it's foolish, having done whole gland TULSA Pro, I don't see any advantage. I have persistent testicular pain. Intermittently after that, I had urinary tract infections and epididymal infections, and my wallet was 30,000 lighter. And I walked into UCLA. I paid nothing out of my pocket and had 5 simple treatments, and I was over and done. And 4 years out with undetectable PSA. You're not going to have undetectable PSA after focal treatment. That's just not the way it works.
Yeah, he's just pushing it, and that's probably a success rate below 50% recurrence. So I don't know. Guess he's got a new focal.
You're breaking up your
Yeah,
phone.
I know. He's got a new machine, focal one, so he's pushing it again. So.
Well, I think the problem is it's great when you go to a place like MSK or one of these centers of excellence, but it doesn't guarantee that you're going to have a multidisciplinary approach. And even in those institutions, you'll find people who will push the type of treatment that they like. And I think that's a detriment. If it is focal, it ought to be part of an IRB reviewed clinical trial, and only in that case is focal advised. Like in the RTIRE study, I think there's some advantage to how that's put together, and that you're able to lower the dose to an effective amount that you're treating the whole gland, but lowering it to the lesion so that you treat that with the IRE and hopefully reduce the side effects with the RTIRE study. But otherwise, focal alone just doesn't. I don't understand it.
Okay.
Anybody else have comments on focal?
I would just mention that at MSK, he's not the only guy doing focal. That Dr. Feinberg is there as well. I didn't see him because by that time I had already decided I wanted to do Weill Cornell, but that's the guy I would have seen if I was trying to follow up on any sort of focal at MSK.
Well, anybody else have anything else? Any parting words for us tonight? If not, I guess we'll see you back in 2 weeks. Thank you so much.
Thank you.
Thank you.
Thank you.
Good night.
Good night. Good night.